Hello there, welcome once more to this YouTube channel. Kindly subscribe to this channel. The topic today is joints and ligaments of the pelvic girdle. Joints and ligaments of the pelvic girdle. The primary joints of the pelvic girdle are the sacroiliac and the pubic symphysis. Right here is an illustration of the joints and ligaments of the pelvic girdle. Taking a close look, you'll see the sacroiliac joints between the sacrum and the right and left iliac bones. You will also see the pubic symphysis joints and the other joints of the pelvic girdle. That's the lumbosacral joint and the sacrococcygeal joint. The sacroiliac joints link the axial skeleton, that's the skeleton of the trunk, composed of the vertebral column at this level. So the sacroiliac joint links the axial skeleton and the inferior appendicular skeleton. Recall that the inferior appendicular skeleton is the skeleton of the lower limb. The lumbosacral and sacrococcygeal joints, though they are joints of the axial skeleton, they are very related to the pelvic girdle. Hence, they are considered as joints of the pelvic girdle. You have strong ligaments that support and strengthen all these joints. That's the joints of the pelvic girdle. All the ligaments are illustrated in that diagram. Now let's talk about the sacroiliac joints. The sacroiliac joints are strong, they are weight bearing, and they are compound joints. I'm going to talk about that, why I say they are compound joints. The sacroiliac joint consists of why I say they are compound joints is because you have an anterior synovial joint. So there's an anterior synovial joint. That's the joint between the ear-shaped auricular surfaces of the sacrum and the ilium. So that's the synovial joint, which is in the anterior aspect. And this synovial joint is covered with articular cartilage. Then you also have a posterior syndesmosis. And the syndesmosis is between the tuberosities of the iliac bone and the sacrum. Recall that syndesmosis refers to a fibrous joint. It's a kind of fibrous joint where you have the articulating bones being held together by very strong ligaments or membranes. So the sacroiliac joint is a compound joint, I said, because it's two in one. At the anterior aspect you have a synovial joint, and then at the posterior aspect you have syndesmosis. That is illustrated in the diagram. You see the diagram right here. So you see an illustration of the sacroiliac joint, the anterior aspect, the synovial joint, and posteriorly you have the syndesmosis. The articular, that's the auricular surfaces of the synovial joint, has irregular and congruent elevations and depressions. They fit in and they interlock such that the joint is quite stable. The sacroiliac joints, we say joints because you have one by the right and one by the left. They differ from most synovial joints in that you have limited mobility, and thanks to the interlocking of the articular surfaces of the synovial joint. So mobility is limited, and this is very important because it plays a role in transmitting the weight of most of the body to the hip bones while standing and walking. The weight is transferred from the axial skeleton to the ilia, and then to the femurs during standing, and then to the ischial tuberosities during sitting. So when sitting, the weight goes to the ischial tuberosities, and then when standing, the weight is transmitted to the ilia and then to the femurs. So as long as you have tight apposition between the articular surfaces, the sacroiliac joints remain quite stable. The sacrum is suspended between the iliac bones in the sacroiliac joints and is firmly attached to the iliac bones by the posterior and interosseous sacroiliac ligaments. So you have posterior and interosseous sacroiliac ligaments, which are quite firm and they give stability to the sacroiliac joint. You also have an anterior sacroiliac ligament. The anterior sacroiliac ligament is thin, and you have by the right and the left, so anterior sacroiliac ligaments. They are mainly the anterior part of the fibrous capsule of the synovial part of the sacroiliac joints. So the anterior part of the fibrous capsule is what is transformed to give you the anterior sacroiliac ligament. The interosseous sacroiliac ligament is more abundant and it lies deep between the tuberosities of the sacrum and ilium. And the interosseous sacroiliac ligament occupies an area of about 10 cm squared. They are very important primary structures involved in transferring the weight of the upper body from the axial skeleton to the two ilia of the appendicular skeleton. Now, about the posterior sacroiliac ligaments. They are posterior external continuation of the interosseous ligament. Then you have the fibers of the interosseous and posterior sacroiliac ligaments running obliquely upward and outward from the sacrum, such that the axial weight pushes down on the sacrum, and this actually pulls the ilium inwards, that's medially, so that they compress the sacrum between the iliac bones and locks the irregularly but congruent surfaces of the sacroiliac joint together. Thus, you have stability being affirmed. You have the iliolumbar ligaments as well, which are accessory ligaments that are involved in giving some stability to the sacroiliac joints. So the ligaments, we talk about the posterior interosseous ligament and posterior sacroiliac ligaments, interosseous sacroiliac ligaments, which are very important. And then you have the anterior interosseous anterior sacroiliac ligament, which is weak but also participates in giving some stability to the joints. And of course, you have an accessory ligament, that's the iliolumbar ligament. Inferiorly, the posterior sacroiliac ligaments are joined by fibers which extend from the posterior margin of the ilium. So these fibers go between the posterior superior and posterior inferior iliac spines. So I'm talking about the inferior aspect of the posterior sacroiliac ligaments. You have the sacroiliac ligaments joined at the posterior aspect by fibers extending from the posterior margin of the ilium between the posterior superior and posterior inferior iliac spines. And these fibers go down to the base of the coccyx to form what we call the sacrotuberous ligament. The sacrotuberous ligament is massive and it passes from the posterior ilium and the lateral aspect of the sacrum and coccyx to the ischial tuberosity. And it transforms the sciatic notch of the hip bone into the large sciatic foramen. So the sacrotuberous ligament transforms the sciatic notch into the large sciatic foramen. You also have the sacrospinous ligament. The sacrospinous ligament passes from the lateral aspect of the sacrum and coccyx to the ischial spine, and it further divides the sciatic foramen into greater and lesser sciatic foramen. Note that movements at the sacroiliac joint is limited by the interlocking of the articulating bones and also the sacroiliac ligament, so both give stability to the joint. So the movement is limited to slight gliding and rotary movements, such that When, for example, an athlete is landing after a high jump, or when a weightlifter is weightlifting in the standing position, you have great force, great exceptional force transmitted through the bodies of the lumbar vertebrae to the superior end of the sacrum. And this transfer of weight occurs anteriorly, anterior to the axis of the sacroiliac joints, such that the superior end of the sacrum is pushed inferiorly and anteriorly. So you have rotation of the superior sacrum counterbalanced by the strong sacrotuberous and sacrospinous ligaments. Both ligaments anchor the inferior end of the sacrum to the ischium, preventing its superior and posterior rotation. So hence you have stability afforded here. So you have only slight upward movement of the inferior end of the sacrum relative to the hip bones, and this resilience is provided to the sacroiliac region when the vertebral column sustains sudden increase in force or weight, like in weightlifting, just like I explained a moment ago. So when there is such weight, like in weightlifting, some kind of resilience is afforded thanks to the ligaments that you have in the sacroiliac joints. Now we need to talk about some other joints in the pelvic girdle. That's the pubic symphysis. This is a secondary cartilaginous joint consisting of fibrocartilaginous interpubic disc and surrounding ligaments uniting the bodies of the pubic bones in the median plane. Right here you have an illustration of the pubic symphysis. Taking a close look at it, you see that the interpubic disc is generally wider in women. It's wider in women. We compared, in one of my videos, I did compare male and female pelvis. So you should be able to take a look at that video and you appreciate what I'm saying. The interpubic disc is generally wider in women. The ligaments joining the bones, that's the ligaments you have around the pelvic girdle, are thickened, especially around the pubic symphysis. You have ligaments joining the pubic bones, thickened at the superior and inferior margins of the symphysis. And when they are thickened, you now have the superior and inferior pubic ligaments formed. So you have superior and inferior pubic ligaments. The superior pubic ligament connects the superior aspects of the pubic bodies and interpubic disc. It extends as far laterally as the pubic tubercles. Don't forget to look at the diagram to appreciate what I'm saying. So you have the superior pubic ligament. You also have the inferior pubic ligament, which we also call the acute ligament. And this one is thick. It's a thick arc of fibers that connects the inferior aspects of the joint components. The inferior pubic ligament rounds off the subpubic angle because it forms the apex of the pubic arc. Remember, the pubic arc we also compared in the male and female pelvis. The decussating fibers of the tendinous attachments of rectus abdominis. Remember, the rectus abdominis and a muscle you see in the abdomen. So it decussates, and the decussating fibers of the tendons of the rectus abdominis, as well as the fibers of external oblique muscles, also give some stability. They strengthen the pubic symphysis anteriorly. So in addition to the superior pubic ligament and the inferior pubic ligament, you also have the fibers of external oblique muscle and the decussating fibers of the rectus abdominis, all giving some stability to the pubic symphysis. Next, I need to talk about the lumbosacral joints. The lumbosacral joints, as the name suggests, is the joint between the last lumbar vertebra, that's the what we call the L5, the fifth lumbar vertebra, the joint between L5 and S1, that's the first sacral vertebra. So both L5 and S1 articulate at the anterior intervertebral joint, which is formed by the intervertebral disc between the bodies of L5 and S1. They also articulate at two posterior zygapophyseal joints, and these joints are facet joints. You have the zygapophyseal joints between the articular processes of L5 and S1. There's a diagram right there illustrating the lumbosacral joints. Taking a close look, you will see the articulation between L5 and S1, that's the lumbosacral joints. The facets on S1 vertebra face posterior medially. Look closely at that diagram. You see that the facet of S1 vertebra faces posterior medially, and it interlocks with the facet of L5, which is anterolateral. So the facet of L5 is anterolateral, interlocking with the facet of S1, which is posterior medial, and they interlock and fit well such that you have prevention of the lumbar vertebra from sliding anteriorly down the incline of the sacrum. The lumbosacral joint is strengthened by fan-like iliolumbar ligaments, which radiate from the transverse processes of the fifth lumbar vertebra to the ilia. So much so for the lumbosacral joints. We say joints because you have an anterior aspect between the bodies of L5 and S1. Then you also have some articulations, two articulations between the articular processes of L5 and S1. So we say lumbosacral joints. The S is there at the end. Next, I need to talk about spondylolysis and spondylolisthesis. Spondylolysis is a defect which affects the vertebra. Spondylolysis is a defect allowing part of a vertebral arc. Remember, the vertebral arc is the posterior projection from the vertebral body that surrounds the spinal canal and bears the articular processes, the transverse processes, and the spinous process. So spondylolysis is a defect allowing part of the vertebral arc to be separated from its body. So this defect, spondylolysis, there is a defect of a vertebra such that the vertebral arc is separated from the body. What happens in spondylolysis? Commonly, you have it affecting the fifth lumbar vertebra, L5, and it results in the separation of the vertebral body from part of the vertebral arc bearing the inferior articular processes. The inferior articular processes of L5 normally interlock with the articular processes of the sacrum. I said that a while ago at the lumbosacral joint. So now when you have spondylolysis and the body of L5 separates from the arc, and I said it's going to affect the inferior articular processes of L5. You have one on the right and on the left, so they could be affected. What do you have as a result? The intrusion of the body of L5 into the pelvic inlet. It reduces the anterior-posterior diameter of the pelvic inlet, and that makes me very worried. This may interfere with parturition, that's childbirth, when the anterior-posterior diameter of the pelvis is inadequate. So if a woman is affected, such a woman might be told she cannot go for vaginal delivery. She might need to go for a cesarean section. Obstetricians test for spondylolisthesis. You have what we call spondylolisthesis. Spondylolisthesis is actually when you have the L5, the body of L5, sliding anteriorly on the sacrum. Spondylolisthesis, when you have a defect affecting when the defect is bilateral, such that the body of L5 now slides anteriorly on the sacrum, the condition is actually called spondylolisthesis. And the body of L5 overlaps the sacral promontory, and then you now have the intrusion of the L5 body into the pelvic inlet. This reduces the anterior posterior diameter of the pelvic inlet. So this condition is actually called spondylolisthesis. And when the anterior posterior diameter of the pelvic inlet is reduced, this may interfere with parturition. So it's actually in spondylolisthesis that you have the anterior posterior diameter of the pelvic inlet affected, and this might affect parturition, that's childbirth. If a woman is affected by this condition, she might be told by the obstetrician that she cannot have a normal vaginal delivery, so she might have to go for a cesarean section. In spondylolisthesis, you might also have compression of the spinal nerves. You could also have compression of the spinal nerves, and this results in lower pain around the lower part of the back. You could also have lower limb pain. So usually obstetricians test for spondylolisthesis by running their fingers along the lumbar spinous processes. When they do so, if they notice any abnormally prominent L5 spinous process, it indicates that the anterior part of L5 vertebra and the vertebral column superior to it must have moved anteriorly relative to the sacrum and the vertebral arc of L5. So they could also use medical images such as sagittal magnetic resonance imaging. When you do a sagittal section of that, you take a sagittal section of magnetic resonance imaging, you could confirm the diagnosis of spondylolisthesis, and then you, from the medical image, from the MRI, the image you have, you could measure the anterior posterior diameter of the pelvic inlet. So it helps the obstetrician to assess the patient that is affected, and then you know if you are really in trouble, if the woman will have a difficulty with parturition. So actually, spondylolisthesis and spondylolysis, they are conditions that come up from the lumbosacral joint, when you have a defect with the lumbar vertebra especially, and the body separates from the arc, and then the body tends to move anterior to the sacrum and goes into the pelvic inlet. I'm still talking about the joints of the pelvic girdle. I need to talk about the sacrococcygeal joint. Now, the sacrococcygeal joint is a secondary cartilaginous joint. Remember, we have primary cartilaginous and secondary cartilaginous joints, like the symphysis. This one is the sacrococcygeal joint is a secondary cartilaginous joint with an intervertebral disc. Right here you have an illustration of the sacrococcygeal joint. So as the name implies, the joint between the sacrum and the coccyx. When you look at the diagram, there is a green portion there, a green portion, an encircled portion. That is actually the sacrococcygeal joint. You have fibrocartilage and ligaments which join the apex of the sacrum to the base of the coccyx. That occurs at the sacrococcygeal joint. At the sacrococcygeal joint, you also have anterior and posterior sacrococcygeal ligaments, which are long strands that reinforce the sacrococcygeal joint. These anterior and posterior sacrococcygeal ligaments are just like the anterior and posterior longitudinal ligament you find around the vertebral column, and you find it around the superior vertebrae. But here at the terminal part of the vertebral column, what you have around the sacrococcygeal joint is the anterior and posterior sacrococcygeal ligaments, trying to afford some stability there. So we need to talk about a puzzle before I call it a day. That pertains to the relaxation of pelvic ligaments and increased joint mobility during pregnancy. So what about relaxation of pelvic ligaments and increased joint mobility during pregnancy? In pregnancy, what happens? The interpubic disc of females increases in size during pregnancy, especially at the later part of pregnancy. This change in size increases the circumference of the lesser pelvis of the female, and it contributes to increased flexibility of the pubic symphysis. Why do you have this kind of situation? Because you have increased levels of sex hormones and also a particular hormone you call relaxin. The levels increase in the later half of pregnancy, and this causes the pelvic ligaments to relax during the later half of pregnancy. So when the pelvic ligaments relax, what happens? You have increased movement at the pelvic joints. Relaxation of sacroiliac ligaments also occur, and you have the pubic symphysis also having some increase in diameters, mostly the transverse diameter. So when you look at the pelvic diameter, there's increase in transverse diameter. You also have the interspinous distance also increased. And all this we like all this because it facilitates passage of the fetus through the pelvic canal at childbirth. The coccyx is also allowed to move more posteriorly, so it's giving more space to the baby. So when it's time for delivery, the baby comes out happily. Then you also have one diameter. You should note that there's one diameter that remains unaffected. That's the one dimension. The true conjugate dimension appears to be unaffected in the later half of pregnancy, because between that diameter you have between the sacral promontory and the posterior superior aspect of the pubic symphysis. So it appears to be unaffected even when the other pelvic diameters are increased. Relaxation of sacroiliac ligaments causes that interlocking mechanism that you have in the sacroiliac joint to become less effective. So you have greater rotation of the pelvis, and you have women tending to have the lordotic posture you have. So the posture of the woman becomes more lordotic at the later part of pregnancy. And you have change in the center of gravity. The center of gravity tends to go more anterior. So don't forget that the relaxation of this pelvic ligament is not actually limited to the pelvic ligaments alone. You also have relaxation of ligaments all over the body, such that the possibility of joint dislocation increases during the later half of pregnancy. So the pregnant woman needs to take things easy. Thank you so much for listening. Don't forget to subscribe to this channel. Goodbye for now.